Welcome, everyone, to the Conversations in Cardiology for SCAI. My name is Frank Ng, and I am the associated editor for the journal. And today we're going to be discussing a really interesting paper that was authored by Dr. Sivakumar out of India. And the topic is on the sinus venosus ASD occlusion and some of the novel techniques that's come out of this. And I have two distinguished panelists with me, Shakeel Qureshi, also known as Shak because he's been knighted as well, and he's from out of London. And the other panelist is Eric Rosenthal, also from the UK. And so welcome everybody to this session here. So why don't I start with Siva presenting your paper first.
Thank you, Frank, for including this topic for SCAI discussion. The paper that we are going to discuss today is our recent publication, which is titled New Covered Stent Design for Correcting Sinus Venosus Defect and a Novel Deployment Technique. If you look at the congenital heart disease structural interventions, one of the recent promoted intervention is sinus venosus defect covered stent closure. I'll first take you to one standard way in which these patients are assessed. So this is a patient who is having a sinus venosus defect, a 50-year-old lady with mild pulmonary hypertension, a single focus pulmonary vein of the right pulmonary vein draining into the SVC-RA junction. The superior vena cava measures about 21 to 22 millimeter. So it's a common practice for us to choose a balloon that is about 4 millimeter larger so that there will be a snug fit of the superior vena cava. So this is a 26 millimeter long, 8 centimeter bib balloon that is positioned across the SVC-RA junction. And the right upper pulmonary vein is being monitored through a transeptal puncture, a Mullin sheath with pigtail placed in the pulmonary vein. Here we are appreciating that the pulmonary vein completely redirected towards the left atrium, filling the left ventricle with no filling of the right atrium. There is no obstruction of this pulmonary vein with equal pressures recorded in the left atrium and pulmonary vein. So a 79 millimeter covered standard Zephyr stent is mounted on the same balloon, positioned across the pulmonary vein. And when it is fully expanded, we find that there is a smooth pulmonary venous redirection towards the left atrium with a complete closure. There is no fabric leak, there is no foreshortening. So this is the standard sinus venosus defect covered stent closure. Now let us come to what is the new paper talking about. There will be a few patients who will have an additional right upper pulmonary vein draining separately higher than the usual right upper pulmonary vein, high in the superior vena cava, sometimes almost at the level of azygos or even high above. Whenever we have such a situation, if we put in a covered stent and that is covering this additional pulmonary vein, the small lobe of the lung will get a venous infarction. So the same patient, when we are doing a catheter angiogram, the right upper pulmonary vein is cannulated with a pigtail catheter and the additional pulmonary vein is cannulated with an end hole catheter. And we are able to appreciate the two veins draining separately, far apart from each other. And when we are interrogating the main right upper pulmonary vein on a balloon interrogation, we find that that is getting redirected. But it is quite possible that this upper pulmonary vein will never get redirected because of the long distance between the main pulmonary vein and the additional pulmonary vein. So in these patients in the past, we used to use a covered stent at the bottom, overlap with a bare stent at the top, so that the anchor of the stent is sufficient, the stent does not embolize, but the additional pulmonary vein will drain through the side struts into the main superior vena cava. This was the standard practice that we were following till a few years ago. We recently got in a new design, which is called as the hybrid partly open stent. So this stent is characterized by its total length of 8 centimeter, of which the superior 20%, that is 16 millimeter, is bare, and the remaining 64 millimeter, that is 80%, is fully covered. And this PTFE covering is welded onto the metal by a technology called as sintered lamination, wherein there is no peeling away of this PTFE fabric from the metal. And this is the normal way in which we mount it onto a long balloon. However, in this technology, in this particular situation, what we do is we also parallelly park a guide catheter, a small guide catheter, which is 5 French. We make the guide catheter take an exit between the junction of the covered part and the bare part of this hybrid stent, so that the guide catheter will emerge out between this proximal 16 millimeter and the distal 64 millimeter. Once this guide catheter comes out, both of them are crimped together, and once it is crimped, there is a protective sleeve that goes around it, and the whole assembly is taken through the long introducer sheath, which may sometimes be 20 or 22 or 24 French, the Cook introducer sheath. So this is the situation where that additional right upper pulmonary vein is cannulated with the Amplatz superstiff guide wire, and the main jugular vein is cannulated with a Landerquist wire. So we take the balloon port through the Landerquist wire and the guide catheter through the Amplatz superstiff wire. So as soon as we reach the target, these two will diverge out, thereby making the bare part of the stent go up in the high SVC, and thereby ensuring that the right upper pulmonary vein, the additional vein, is always into the uncovered part. Once we expand the stent, subsequently when you make an injection through that guide catheter, we can appreciate that the additional pulmonary vein is draining into the superior vena cava without any obstruction. So there is no risk of venous infarction of this area, and the main pulmonary vein completely gets redirected into the left atrium. Since we have taken the catheter through the Amplatz superstiff wire that was already parked in the right upper pulmonary vein, it is almost certain that there will not be an occlusion of this pulmonary vein. When we use the same stent directly, there may be a possibility that we may miss this target, because there is no way to precisely identify this pulmonary vein unless we have a catheter that is parked. You cannot park a catheter and expand a stent, then it will be difficult for you to take out that catheter. The second anatomy where it's going to be useful is in patients who have a very short superior vena cava anchor. See the CT scan here where the right and the left innominate vein join together, and the pulmonary vein is almost draining at the same level. This is in this group of patients that the surgeons will be doing the so-called Warden anastomosis, where they will cut the superior vena cava here, drag it down to the atrial appendage. Now, how do we achieve a covered stent in this patient with only a short SVC anchor? When we do the angiogram, we identify that it's just about a little more than 1 centimeter, and that is too short to be a stable anchor. So what we do in this particular situation, we park a transeptal catheter, put in a pigtail into the uppermost pulmonary vein tributary, and make a standard angiogram. And once we have identified it, we park a Amplatz superstiff guide wire in the left innominate vein. So this is the long left innominate vein Amplatz superstiff guide wire. The standard Landerquist guide wire goes in the jugular. You take this covered stent so that the distal 3 struts will be going into the innominate vein, and the open part will be exposed towards the left innominate vein. After you expand it, you will identify that the pulmonary vein, the left innominate vein, is draining uninterrupted into this covered stent. So this is also a 2-wire strategy where one wire is in the right jugular for the main stent, and the other wire is in the left innominate vein for protecting the left innominate vein. So this new hybrid stent with a novel 2-wire deployment technique is a valuable strategy. Since sinus venosus defect closure is increasingly becoming more accepted as an alternative to surgery, evolutions of techniques and evolutions of stent designs should emerge to cater for all the anatomical variations in this complex anatomy. The new hybrid stent is going to be useful in those who are having additional high draining pulmonary vein. In our group of about 150 patients, on CT scan, we identified 17% of the patients to have such a high draining additional pulmonary vein. And similarly, those with a short SVC anchor. More experience of newer techniques as well as innovative stent designs would help the operators across the world to cater for more and more patients. Thank you.
So congratulations, Siva, for these novel, impressive techniques to overcome some of the anatomical variations. So thank you for presenting that. Let me just ask a few questions to the group, and we can have a free discussion here. So we know that historically, occluding the sinus venosus ASD was probably first presented at some meeting by Hussein Abdallah in Baghdad. I think, unfortunately, he didn't publish his paper until 2020, and the first paper was written by Garg in 2014. I know Shaq and Sivar and Eric, you guys have actively done many cases here in Europe and India and the rest of the world. And I know, Eric, you actually was the first author paper in a recent international registry for this procedure. So thank you for doing that. So let me ask you guys, how did you guys first come to embrace this procedure? What I mean by that is that, at least in the US, we often have to have long discussions to convince the surgeons to agree and to back us up in case something goes wrong. And so how did you guys convince your surgeons to give up these procedures for the cath lab?
Just before you go into that, Frank, one minor correction, and that is, although Hussein Abdul Wahab reported it at CSI in 2013, when we actually looked at the literature, there was a paper written by Ryan Butts, and Bob Anderson was the senior author, which was actually dealing with morphology. And within it, there was a passing mention of a catheter implantation of a stent graft for a sinus venosus defect. And that was done by, and I sort of chased it up and thought, well, this is earlier than Hussein's. And it was Rani Bandisod from, I think, South Carolina, who actually did the procedure in 2009. And there was a passing mention of this in Bob Anderson and Ryan Butts' paper. So I contacted them and said, well, you completely ignored the operator, that hasn't been corrected. So just a minor correction. And then I'll pass to Eric about how we went about proceeding. Eric.
So I first came across the procedure when I read the paper in 2014, and I have to confess I didn't really understand the anatomy from the paper. Not that they didn't explain it well, I just didn't quite get my head around it. But probably 3 months later, a 60-odd-year-old man, I'd say a young man because he was about 3 months younger than me at the time, came to see me, and he said he's been told he needs surgery for his sinus venosus defect, but he doesn't want it. And I said, well, surgery is the standard approach to this. Hang on, I saw a paper that says you can use a stent. Let's explore it further. So I printed a 3D model of his heart, and I mean, that took some time to do. And I put a stent in it. I took it to my surgeon. He took one look at it and said, you can do a better job than I can at a much lower risk. And he was happy with it, having seen the 3D model with a stent in place. I then put it through all our governance committees, and we got permission from the health regulatory authorities. It took about 2 years to do that. And in 2016, we put in a stent using the Tenzig covered CP stent, probably the first one of this type of stent, and it worked brilliantly. And I actually just saw the patient a few months ago. He came up to do a promotional video for the British Heart Foundation, and he's delighted with the procedure. And I thought this would be a one-off. And then we had a patient who'd had previous surgical repair with residual defects and needed a pacemaker. So we closed his defect with a stent, put in a pacemaker, and then it just went on a roll. And I think round about the same time, Siva started doing them. And then between us, we've done several hundred, and really the results have been very, very good.
So unlike the surgeons elsewhere, especially US, in certainly UK, there was a little reluctance initially, but as Eric said, a lot of the time now, the surgeons actually say to us, what about this case? You know, do you think it's suitable for a catheter? And so there, a lot of it is it's a mind game, isn't it? Really, and it's fairly easy to convert them once you show them.
Institution, the secundum ASD is by default catheter and surgery if that fails. And in our institution, we now routinely screen the patients for catheter closure, and only if it doesn't work or there's reluctance for some reason would the surgeons even have a chance. They don't get first offer at all.
Well, that's great. I mean, I think that all collaboration should be done that way. Siva, how did you handle this in India?
I was in 2013 when Hussain Abdullah was presenting oral abstract. I was one of the chairpersons, and many of the people in the audience were very annoyed by how can this complex anatomy ever be addressed by such a method. In fact, there were a couple of patients who had a resident. In fact, the history of Hussain Abdullah goes even back to 2.5 years. He presented his data of 4 cases over 2.5 years. So 2 of the cases had residual ASDs where he put in 1 Amplatzer septal occluder and 1 cribriform device. So, but coming back home in 2014, there was a lady whom I was serially catheterizing every year for a sinus venosus defect, severe pulmonary arterial hypertension, because her numbers would never come to operable range. She will always stay at 5.5 Wood units or 6 Wood units and show very minimal response to vasodilator testing. So we kept on giving her pulmonary vasodilators, and serially we were testing her. During the 3rd assessment, the data was slightly becoming positive, and I was tempted to use a balloon occlusion in order to see whether a temporary balloon occlusion will result in any change in the pulmonary artery pressures. Lo and behold, the pulmonary artery pressure, which was originally about 80/40, dropped down to 25/15 the moment I put in the balloon without altering the aortic pressures. We might think that superior vena cava obstruction is possibly causing a fall in the cardiac output, and so everything is going low. But the aortic pressures were maintained, but the PA pressures were going very low. I took the data to the surgeon and told the surgeon was convinced that he will operate. But then this patient herself was asking, if you can occlude with a balloon, why can't you have a permanent balloon there and keep it permanently fixed there, ever in my life? So then we thought about Hussain Abdullah, and then that was our first case.
That's fantastic. So let me ask you guys, for people who are just starting this, obviously the things that people worry about is stent embolization or obstructing pulmonary veins. I think those are 2 major complications we have to avoid. And so can you just go over with us some of your pre-planning techniques and the technologies you use? I know that, Eric, you talked about creating 3D models and putting stents in to see how it looks. Can you go over that a little bit for the people who have not done a lot of this?
So what I'd say, we started out using 3D models. We don't anymore. We take a very careful look at cross-sectional imaging. We find the CT scanning is much better than an MRI scan. But I think whatever people do, I think it's useful when you start out to make some models and play around with them. But at the very least, you should watch a few live procedures, and most interventional conferences will have some live cases. You should go and watch in another institution how a case gets done, and perhaps be proctored by someone nearby, or if necessary, someone international, to just come and guide you through the first couple of patients. And then I think it becomes fairly straightforward to do. And you can then jump onto the learning curve rather than having your own learning curve for this.
The other thing, just to add, Frank, is if you're going to start off, having done what Eric has just proposed as well, start with the most suitable case, suitable anatomy case, before taking on the challenging, more difficult cases, such as the examples that Shiva has shown. So that, you know, again, if you do those, you'll get institutional and surgeon support, and then you can progress after that.
So Shak and you know that I showed the case to you guys and getting some advice, and the very first case I did had 4 anomalous branches of the upper and the middle. So that was not a good one. Don't think I've ever prepared more for a case than this one.
We said don't do it, Frank.
That's right. Yeah.
But you did.
Yeah, and succeeded.
So Siva, you were saying something.
Yeah, the main important way to avoid a stent embolization is to have a sufficient superior vena cava anchor, which means you should have an access to the long stents. Since the conventional FDA-approved stents stop at 6 centimeter, if you try to experiment out with these shorter stents, there are going to be instances where you'll have a fear whether I will not be covering the lower part sufficiently. And so you sort of tend to push the stent a little below, thereby getting an inadequate superior vena cava anchor. So the best way will be to get access to longer stents, which means stents that are at least 7 centimeter, if not, if even better, it will be 8 centimeter in a standard adult patient. The longer the stent is, your anchor is better, and the chances of embolization is less. If you're having about 2 centimeter of superior vena cava nicely gripping the upper part, I think the stent embolization may not happen.
Recently, I had heard about, I think from the guys from Brazil looking at 3D goggle technology. And I have to say, for my first case, I actually did that at our institution, and I found it to be actually very helpful. We had a simulation of a stent, a G armor, and put it in and looked at each of the orifices of the pulmonary veins. That's how I knew that the second and third branches in the middle were the ones that had potential for obstruction. And with that in mind, I was able to actually prepare for that. Can you guys talk a little bit about that new technology? Have you guys employed it?
These are the only goggles I use.
Okay.
So virtual reality, sorry, Shiva, go ahead.
Yeah, we have access to 2 of these virtual reality softwares, both of which emerge from Poland, actually. One is called the vMersive, and second is VIA Medical. Both of them are Poland-based softwares. We have an access to this, the so-called Google lenses and, the joysticks. But having born in an era when all these video games were not popular, if I wear it for more than 5 minutes, I get terrible headaches. while my junior colleagues are extremely comfortable. They even stand for 2 hours with this virtual reality goggles, and they keep on playing with it. For me, it's maximum 2 minutes or 3 minutes, then I get headache, nausea, and it really triggers your vestibular apparatus.
I get more than that. I get dizzy as well.
It's funny. I actually had the same thought. I said I did not grow up in the era where people played a lot of video games, or at least I didn't get interested in it. And my younger partner just had a great time with it, but I had a hard time controlling the 2 controllers. But in the end, it was actually very helpful to me.
Did you use it during the case or
No, it was pre-planning.
We also have a virtual reality system, which is fun to use, but it takes time to do. So I think in difficult cases, it's quite nice to use that and plan, as you say. I thought you meant having real-time virtual reality while you're doing the case. I think that would just be too much.
This was all pre-planning. This was a first case I had done, and I just wanted to be as careful as possible. So I just employed whatever technology we had available. And after hearing about this at one of the meetings, I tried it, and actually was very helpful to know which of the vessels were I had to pay attention to. So that was good.
And VR software depends on what you use, but it gives you you can chop it in different axes, and if you look from above, you can see how the pulmonary veins from the right side would actually either be obstructed or not obstructed. So it does have an important role in assessing.
Yeah.
I think there are 2 kinds. The ones where you have to segment the heart, and I think that's the type you use, Shiva, which can take an hour to segment the heart. We have a virtual reality system where you don't have to segment the heart at all. Just put it straight in, and you can put the stent in, and you can do it in 5 minutes to play with.
Yeah, but, the same thing. The vMersive and VIA Medical are like that. It's within the moment you get the data loaded on the computer from the CT, it's within a matter of minutes you'll get it. It's not time consuming.
Right.
So one of the, I'm going to keep going with questions. One of the questions that often come up with implantable devices, anticoagulation, antiplatelet therapy. Tell us, what is your short-term and long-term management plan?
Well, maybe I can start on this. In the first 100 cases, we were using aspirin and Plavix for 6 months as our antiplatelet strategy. We were using, in the first 100 cases, close to about 45 of them were covered CP stents, and the remaining were covered cobalt chromium stents, which are available either from Germany as covered Andramed or covered Optimus Sevius, or we had our own Indian stent called as the covered Zephyr. We found that at the end of the first 100 cases, we had identified 5 patients with thrombosis. All of them were asymptomatic. At the lower end of the stent, very often it will be layered within the inner lumen and not causing any symptoms for the patient, no SVC obstruction. It will be a very thin layer of thrombus identified on transesophageal echo. So we decided to change our strategy to NOAC, that is rivaroxaban plus aspirin, in the next 50 cases. Now we are touching close to about 160 patients now. In the last 60 patients, we have not seen a primary thrombus. In the previous patients where we identified 5 of them to have thrombus, we treated them, all of them, with either coumadin or with one of the NOACs. And in a matter of about 3 to 6 months, they all became very less. But still, there was a very tiny, maybe 1 or 2 millimeters of a layering still persisting. So our anticoagulation strategy currently is aspirin and rivaroxaban or Xarelto for a period of 1 year. Our imaging protocol is at 1 month, 6 month, and 12-month transesophageal echocardiography for everybody. The reason why we prefer a transesophageal echocardiography is that there are no metallic artifacts caused by the metal stents on the CT scan. CT scan produces, whenever there is a metal, it produces some amount of shattering artifact, and there are some black spots, and we will not be able to differentiate a thrombus from an artifact. The second is radiation dose with the CT. And third will be the spatial resolution and the temporal resolution is far superior. We will get very, very comfortable view. And there is no need to schedule. I see the patient in my clinic and immediately I move the patient into the transesophageal echo room and immediately do it off. So there is no scheduling time. I am able to give more comfort for the patient because I send them home within 3 hours or 4 hours after their visit. So for multiple reasons, TE seems to be the preferred choice. Since we do a small children also, in younger children who may not tolerate outpatient transesophageal echo, we do MRI. So this is our imaging protocol.
Eric.
Yeah, Shiva, I wanted to ask you about your thrombi, because when I reviewed your first 100 paper, many of them seem to be in patients with bilateral SVCs where the top end was 8-10 millimeter SVC diameter and the bottom could be flared up to 30 millimeters. So do you think that's the particular issue where the stent suddenly flares out, rather than in the majority of patients where, say, it goes from 20 down to 26 millimeters? Probably there's no discrepancy and the flow dynamics are not going to be an issue.
Yeah, we did a multivariate analysis on multiple factors. What we found was among the first 100 patients, it is known that about 20% of patients who are having sinus venosus defect will have a bilateral superior vena cava. So the incidence of left superior vena cava is 20%. While the 5 of the patients who had thrombus, 4 of them were bilateral superior vena cava, whereas the remaining 95 patients, 19 of them had bilateral superior vena cava. So the incidence was like 4:1 for patients who are having bilateral superior vena cava versus single superior vena cava. We also felt that could be a factor because the superior vena cava, when it is in the narrow portion, the blood will have a higher velocity. And as soon as it reaches the broader portion, it becomes like a delta where the river enters the sea and there is going to be some sluggishness of the flow, and the flow that may result in sort of layering of the thrombus on the walls. We also felt so. And in fact, in the recent about 60 patients where we are insisting on NOAC plus aspirin, we specially warn the patients who are having bilateral superior vena cava that they should be very, very meticulous in taking the anticoagulation, and it is of great importance. Thanks for bringing out that point. I think this double superior vena cava where there is a size disparity between the top end of the stent and the bottom end, I normally teach the patient like it's like how the river which is flowing with a high velocity. Suddenly, as soon as it reaches the sea, it becomes very slow, and the blood goes so slowly that all the particulate material gets deposited. That's how I teach the patients. So I think it's an important point.
Jack, what is your anticoagulation, antiplatelet therapy?
Well, we give dual antiplatelets, aspirin and clopidogrel, for 6 months, usually between 3 and 6 months, and then it's stopped. But the problem with all of that is, in a way, it's not based on any scientific data. So what we don't know, and I'm sure it applies to Shiva's patients in particular, is what the resistance is, or the incidence of aspirin resistance and clopidogrel resistance, because there's an increased incidence of resistance to both of those in the Asian or Far Eastern population. And nobody checks for that, and therefore we have no scientific basis for either giving aspirin and clopidogrel or rivaroxaban and aspirin.
Eric, do you follow the same protocol?
Yeah. Shaq and I developed that same protocol. We just said, well, 6 months. That's how we developed it. Unlike Shiva, we don't do a TOE, so possibly we could be missing small subclinical ones. I think the other factor is important, trying not to have too much of the stent hanging in the right atrium. It's ideal to have it perfectly placed, but as we all know, oftentimes you have to have too long a stent to get it right.
Yeah.
And that's unavoidable, I think.
Yeah. I know we're running out of time. For those who are just starting out in this procedure, I think in the US, many places have started doing this, but it's still early in everybody's experience here. What advice would you give to somebody who wants to start this program?
Well, I would tell them that, number one, convince or show their surgeons the data that's already published. So we've got several hundred, 370, I think, or something like that for the international registry. And that's just a relatively small number. And there are other units doing it. And so there are increasing number of cases that are being done. So that will help to overcome the surgical mindset. And then the next thing would be to go for the best anatomy in fully grown patients, and then after that start expanding into challenging anatomies and very young patients. We haven't really addressed the procedure recommendations for children who are still growing, what the guideline should be. So that area needs a little bit more caution.
I think Shaq's right. You need to learn to walk before you run. I can remember proctoring at another center. We did 3 cases on one day, all put the stent in the same way. We had one stent and then we anchored the stent. It all went really well. But the 4th case that was done after I left, they decided to put in a landing zone stent before they put in the stent, and they didn't anchor this stent, which then embolized the next day. So I think you've shown how to do something, and then almost immediately you decide to alter it because you think you can do better. I think a word of caution with this: see how it's been done, follow the pattern. When you've got a few under your belt, then you can explore, then you can start doing the double wire technique that Shiva's been doing, etc. Shiva, we've actually done a couple of double wires, although not with the hybrid stent because we don't have that available at the moment, but by putting the second balloon just out the top of the stent, and that actually helps get the first stent at the right place.
And of course, Frank
really good technique.
And of course, Frank has done a case with 2 balloons at the same time as he's implanting the stent.
Yeah, I didn't follow that advice. My first case was probably pretty complex with your double wire technique and the double ballooning. And again, I don't know how I got myself into that, but luckily all went well.
I think the people who are venturing into it should study the CT anatomy very carefully. And I think they should try to use whichever method of analysis. Some of them may be comfortable with multiplanar reformatting, which means slicing the heart in different axial planes and trying to orient the right upper pulmonary vein towards the left atrium and try to get a better understanding and subsequently venture into the case, because a thorough understanding of the CT anatomy gives a far better insight onto this intervention. It's a complex three-dimensional anatomy. Managed with a single covered stent, with the premise that the venous blood goes through the middle of the stent and the oxygenated blood goes on the outer side. So that orientation, a person should look at the CT carefully with either a volume rendering method or a multiplanar reformatting, and try to understand the CT as best as possible.
Well, thank you very much. I know that we've run out of time, and I really appreciate your participation and a fantastic discussion on this topic. Thank you very much.